aorta. So this is the example of the aortic flow patterns. So you can aim for a target vessels or target vessels, including aorta, PA, superior vena cava, and so on, that generate the data for cardiac output from my blood flow and QPQS. You can get the quite accurate intracardiac shunt, bar regardless fraction, and then amount of AP collaterals. So it does gives us a better sense of current physiology, which can be fluctuating, and provide additional or sometimes essential information to guide our decision making. So I'll give you sort of three good examples how we utilize this cardiac MRI data in the surgical decision making. And towards the end, what we can discuss, what we can do in the future utilizing this technology. So this is the first story. I'm just going to go back. So the first story is about borderline left ventricle, and then borderline left side structure in terms of decision making in a single ventricle versus two ventricles, primary versus staged repair. And then the second example is the pre-stage 2 palliation for the single ventricle palliation with special attention to the SBC flow. And the last example is the prometasia MAPCAS to look at the preoperative pulmonary blood flow. The first example is the borderline left ventricle. So this is the outlining SICCH algorithm for the borderline left ventricle. And for those patients who meet the criteria for borderline left side, we routinely perform cardiac MRI as a neonate in the first week of life, and we determine the left ventricle end-diastolic volume index. So based on that, we decide what to do. If it's really small ventricles with a LV-DBI of less than 18 ml, plus minus significant aortic and mitral valve disease, we opt to do single ventricle palliation in form of node procedure with SAN or shunt. And the subgroup of interest is this patient who have borderline left ventricle as a apex forming, a non-apex forming, but seems to have a potential to grow. So those patients, we use the hybrid stage 1 procedure to give them time and then try to grow the ventricle. And then repeat the cardiac MRI in 2 to 3 months, and then determine what to do. So either a single ventricle path or two ventricle pathway. And then in terms of cardiac MRI, so this the right panel. I'm not sure you can see my cursor, but we obviously pay attention to the left ventricle end-diastolic volume index, but also pay attention to the ascending aortic flow. That's obviously indicative of cardiac output through this small left ventricle. Flow through the atrial septal defect is very important because that's really steals blood flow that can come into the left ventricle. And then also direction and then flow across the PDA is also important to understand the physiology. So hybrid stage 1, as you know, we use typically 3.5 millimeter Gore-Tex shunt, just cut it in so 2 to 3 millimeter width, and then ductal stenting. So we do this in as a primary procedure. If we know that we're gonna stay for a while, or we do it in a staged manner. Starting with the bilateral PA banding, and then when we decide to do a full biventricular repair after hybrid stage 1, Then we'll do arch reconstruction, and then typically banding and then patch reconstruction of the pulmonary artery, such as this. And then if there's a mitral valve pathology, we'll work on the mitral valve, and then plus minus EFE resection, although we're not super aggressive in terms of EFE resection at the time of biventricular repair. And then we typically use the adjustable AST to 3 to 4 millimeters, leave it alone to leave it open to decompress the left atrium. So if you look at this, our cohort of the patient who have a hybrid stage 1 as a bridge to biventricular repair, most of the patient, vast majority of patients have a LV growth that's shown by the LV, EDB, EDBI, and then the LV stroke volume, and so on. I'll just give you a couple of interesting examples. So this is a patient who this is a 2-day-old neonate who have a borderline left side, including the aortic valve, which is quite borderline. So Z-score -7. So mitral valve Z-score around -4, and then we know it's double if it's mitral valve. So this is a typical patient that we performed the cardiac MRI, and what's striking about this patient is that ascending aortic flow is very, very low, so 1.5 liter index. And then the main reason is that obviously the left ventricle is quite small, but this patient also have a very large atrial septal defect, having the QPQS of 3 to 1. And LV index is 22, which is very borderline, and then PDA is bidirectional. So given these findings, we did the hybrid stage 1, and then also went on bypass to partially close the AST, because if AST stay very large, it does not force blood flow to go into the left ventricle, and then that may hinder the left ventricle growth. A couple months later, so this is post-hybrid, prior to biventricular repair, the left ventricle is kind of expanding, and then this is a follow-up MRI increase to 41 index, and then the ascending aortic flow have a dramatic increase from 1.5 to 2.4 index, and then very favorable QPQS. That means that LV, that means that the atrial septal defect obviously becomes small surgically, and then also that's indicative of improving the compliance of left ventricle. So we did full biventricular repair. We left a small atrial septal defect, and then left ventricle is nearly normal size now. So this patient kind of followed this pathway. So borderline LV, kind of hybrid, repeated MRI, and then we were happy to proceed with the biventricular repair. So this second patient is quite interesting. This is not necessarily the MRI flow data, but this patient has a sort of flavor of both borderline LV and then also critical aortic stenosis type anatomy physiology. So a small aortic valve, not so small mitral valve, but you can see this quite dramatic hypertrophy of the left ventricle. So what we worry about is obviously this ventricular hypertrophy and then degree of mitral valve regurgitation. Therefore, we did a hybrid stage 1 with surgical aortic valvotomy on bypass. So what turned out to be happening is that this left ventricle stay really muscle bound and hypertrophied, and have a regurgitant aortic valve and then mitral valve, and then we decide not to proceed with the biventricular repair. So this patient had a single ventricle palliation at the end. the beauty of hybrid is that you can decide very early on in the first few months what to do, and still not too late to convert to novel type physiology, as long as lung vasculature is protected by the bilateral PA banding. So this is a third case to show successful biventricular repair, and you can see this for chamber view. It's really scary small left ventricle. So aortic valve is small, mitral valve is small, and then have a small VSD. So ascending aortic flow is not bad. So it's close to 2 liters index, and then QPQS is 2 to 1 through both small VSD and modest size ASD. But the left ventricular index is very borderline, so 22, 21 index. So for that reason, we perform the hybrid procedure. So after hybrid stage 1, so this is a couple months later, the ascending aortic flow does not change that much, but the left ventricle certainly grow to 35 from 21 index. So therefore, we decide to do the biventricular repair. So after biventricular repair, the left ventricle nicely expanded. We still had to watch those left ventricle because sometimes it has pathologic dilatation as opposed to healthy growth, and sometimes have a late dysfunction. So that's something to watch for. So this patient followed this pathway and then have a successful biventricular repair. So this last case, which to this day still amazes me, and this is something that the MRI was extremely useful. So this is a 5-day-old neonate who have essentially moderate arch hypoplasia with tight coarctation and then borderline left ventricle. So in terms of arch anatomy, we could do thoracotomy coarctation repair. But if you look at this four-chamber view, the mitral valve is extremely small, so 5.9 millimeter, which gives you that score of almost -7. And then the aortic valve is also quite small. So we are very worried about this ventricle. Also, worried about this left side structures, although left ventricle itself is apex forming. So we performed the cardiac MRI, and to our surprise, the ascending aortic flow is 2.6 liter index, which is very high. And then there's a tiny AST and then almost no shunting. And then LV-DVI is 29. So based on this, so in the absence of large atrial level shunting, the left side, although it's quite small, is generating more than enough cardiac output. And then this mitral valve, although extremely small by diameter, but does not have functional mitral stenosis. For this reason, we did a coarctation repair, and this patient did quite well. So without this MRI data, we could say this may be too dangerous to perform primary biventricular repair, and it may have opted to do a hybrid. But this MRI data did really help us. So just going to the second sort of topic. So this is pre-stage 2 evaluation for single ventricle patient, particularly using the SBC data to predict post-BCPS physiology. So pre-stage 2 evaluation for any type of single ventricles, we do around 3 to 5 months of age. We do not perform super early stage 2, so we are very kind of standard 5 to 6 months of age. If patient cyanotic, we perform the stage 2 around 4 months of age. So routine the examination, including cardiac echo, cardiac catheterization, and cardiac MRI. We try to combine cardiac cath and MRI in the same anesthesia in the same day. Usually started with a cardiac MRI followed by the cath. In this cardiac MRI, we try to obtain as much information as possible, including morphology and ventricular barometry, all types of vessel blood flow, including ascending and descending aorta, SPC flow, PA flow, pulmonary vein flow. And then beauty of doing the cardiac catheterization and cardiac MRI in the same day is that you can get very accurate pulmonary vascular resistance. So you get the pressure data from cath, and then very accurate flow data from the MRI, and then you can get the good pulmonary vascular resistance index. And then we obtain two different QPQS. So one is based on the pulmonary artery flow, so QPA to QS, which is typically lower than the second QPQS, which is a pulmonary vein to systemic ratio. So this accounts for the amount of aortopulmonary collateral flow, which is not negligible. In fact, some patients have a torrential amount of AB collaterals, and then that gives you a much higher QPV-QS ratio. And then this may reflect the patient clinical pictures compared to QPA-QS, because this is just the amount of flow crossing the shunt. And then we also obtain the regurgitation fraction of valve regurgitation. This is particularly important in a patient with hypoplastic left heart syndrome with some degree of AV valve regurgitation. We also obtain the T1 mapping to evaluate myocardial scar or interstitial fibrosis, and this is particularly important after no type extensive stage 1 procedure. So SPC flow is kind of interesting. We've been paying attention to this phenomenon for many years. So this is phase contrast target SPC, and then this is how it looks like. It's kind of phasic flow through the SPC. So Shura Low was the clinical associate with us several years ago, and then he conducted a quite interesting study to look at the relationship between superior vena cava blood flow and then post stage 2 physiology. So this is this consists of 65 patients who are going down to the BCPS procedures, and the pre-BCPS SPC flow. So this median absolute flow is about 0.5 liter per minute. And the index flow is about 1.7, 1.8 liter per square meter. And then that can be as high as more than 2 liters. And then BCPS takedown occurs in 10%, and then the early or late death happens in 6% of this cohort. So if you look at this, this is really interesting. This is a correlation graph. So on the left-hand panel, x-axis is the SPC index flow, and then y-axis is the post-BCPS saturation. It's very good moderate correlation between the SPC flow and an arterial saturation. In other words, the higher the SPC flow pre-gland, the higher the arterial saturation after surgery. So that makes sense because you have more pulmonary blood flow after the end. And so this right-hand panel is the absolute flow, not the index flow, and then have a similar correlation to the arterial saturation post-BCPS. And if you look at this graph, so this left-hand panel SPC, absolute blood flow on the x-axis, and index flow in the y-axis, and then this red dot are the patient who have either early or late death of any cause or BCPS takedown. So if you look at this graph, so we draw the dotted line of absolute flow less than 0.5 liter, index flow less than 1.6 liter, and then a majority of them, I would say 3/4 of them, are in this subgroup of low SPC flow. If you look at if you divide into two groups based on the pre-BCPS SPC flow, they do have worse outcome in terms of freedom from death or BCPC takedown. So, and then this is the anatomic and physiologic predictor for death and BCPS takedown, and moderate or severe AV valve regurgitation came out as quite significant, and SPC flow pre-BCPS, although hazard ratio is relatively small, but came out as significant. So this is the last subgroup that we think that physiologic data is quite useful to make decisions, which is the subgroup of patients who have promyelotasia, VSD, and MAPCAS. So I've been studying this population for a very long time, and it's quite an intriguing subgroup of patients who have, very heterogeneous pulmonary vasculature. So this patient group, very difficult to predict post-unifocalization pulmonary physiology in terms of total resistance and pressure, which ultimately determine the ability to close the VSD to achieve the full biventricular repair physiology. So best anatomic parameters that's suggested by the Stanford San Francisco group many years ago is something called total neopulmonary artery index, which still the by far the best anatomic predictors of how patient does after VSD closure and unifocalization. So this is a total cross-sectional area of each MAPCAS and a native PA combined, but it does not take pulmonary vascular resistance of each lung segment or blood flow going through each MAPCAS into consideration. So it does have a limitation. Therefore, we think that importance of intraoperative assessment of physiology by doing an intraoperative pulmonary blood flow study. So this is a relatively old study that we've done in SICCH. So the research question was that the intraoperative physiologic measurement by means of pulmonary intraoperative flow study better predict post-VSD closure physiology compared to anatomic parameters such as total neopulmonary artery index. At this era, we used the flow study of 2.5 liter index going into the reconstructed pulmonary artery after unifocalization, and a cutoff value of the mean PA pressure was 30 millimeter mercury. So based on the Stanford experience in the mid-2000, we also followed their recommendation and revised to more conservative numbers, which is to close the VSD when the mean PA pressure was less than 25 millimeter mercury with a higher flow of 3 liter per minutes per square meter. And then if you look at this, so this left panel, upper and lower, is the anatomic parameters. That's the total neopulmonary artery index. And then the right-hand panel, upper and lower, is the mean peer pressure obtained from the intraoperative pulmonary blood flow study. And you can see that you have a much higher correlation between the pulmonary artery pressure obtained by the flow study to subsequent RV pressure after BSC is closed. And that's it. That's also true for the correlation between the peer pressure by the flow study and then the RV systolic pressure ratio. So this is really important. And then as I said, we changed the cutoff peer pressure to 25 with much higher flow 3-liter index in the last 10 plus years, and then it does have a similar trend in terms of a correlation between the peer pressure and RV-LV ratio. So what's wrong with this? This is really predictable and then reproducible. But the problem here is that we don't have any prediction until after full unifocalization and then flow study. So everything's done when you unifocalize all markers and then perform the pulmonary blood flow study. Our question is that can cardiac MRI predict this phenomenon, the feasibility of BSC closure and the post-BSC closure physiology, such as RV pressure, before surgery occurs, which is interesting research question. So this is Lars Gross-Wortmann study. So he was head of the cardiac MRI in sick case in the past, and so this is interesting study. So we have 10 patients who have preoperative MRI before full unitization plus minus BSC closure, and we'll look at the preoperative QPQS and correlate with the anatomic parameters such as total neopulmonary artery index and post-repair physiology. So the QPQS really varies as low as less than 1, which is usually not a good sign, all the way up to 2.7 to 1, which is very high. That's indicative of large markers and then the absence of pulmonary hypertension. So if you look at this, so left-hand panel is a correlation between the QPQS derived by the MRI and anatomic parameters derived by the CAS. So this is the neopulmonary artery index. Interestingly, in this limited patient cohort, there's a good correlation between QPQS on the MRI and in the total neopulmonary artery index, which makes sense. In the absence of pulmonary hypertension, the larger the marker or native PA or combined, the higher QPQS. It does make sense. But the deal breaker will be the pulmonary hypertension, segmental pulmonary hypertension, which could happen in those patients. And then the right-hand panel is a correlation between the QPQS and RV systolic blood pressure ratio, which have a really good correlation. So that means the higher the QPQS prior to unifocalization, they're better off by having a low RV pressure after BSC is closed. And then, so if you could comparing the physiologic prediction by the QPQS derived by the MRI versus anatomic parameters derived by the CAS, they have a very similar high correlation in this specific study. So this is another good example of use of a cardiac MRI to predict what's going on in this, segmental lungs perfused by the markers. So this patient have 2 markers This is a 14 years old patient. It's a late diagnosis of prematasia MAPCA. So one MAPCA have this flow pattern, which is essentially have a critical stenosis, and then stenotic pattern with high velocity continuous flow. The other MAPCA is very big and then unobstructed for the all the time last 14 years. So this MAPCA have a quite hypertensive pattern with a RA systolic peak and an accessory peak in the late systole. So you can guess what's going on in the peripheral peripheral pulmonary vasculature. So in this study, we attempt to measure the blood flow going through each MAPCAs, which is intriguing, and then that probably gives us more insight. But in the small babies, in the infant, it's quite difficult to measure the blood flow through each MAPCAs. That will be next on the agenda. So we went through 3 good examples, how we use the MRI in our surgical decision making. So we're using more MRI to the severe signs anomaly in terms of determining the feasibility of biventricular repair. To me, it's quite useful to know how much functional right ventricle volume is there, and then how much it's going through the atrial receptor defect before the operation to determine the patient can be okay with biventricular with repair with a small ASD versus the patient need a one-on-one ventricular repair. So hypoplastic left right ventricle patient, we are using the MRI. It's hard to interpret the data yet, and then we have not published any data yet. This is on the horizon. And then lastly, the Boston group have published just recently the beautiful demonstration of 4D flow data by the MRI to determine the fading Fontan physiology and the indication to upsize the Fontan conduit. And then that'll be quite useful. So I'm not going to go through that, but we believe that cardiac MRI gives you quite useful additional information, and sometimes it's a critical information to make surgical decisions. And then we're planning to incorporate more of those functional dynamic data in surgical decision making. So this most of the data that I just presented, I wrote this review paper last year, and then have more details. So if you're interested, you can read it through. Thank you so much for your attention, and I'm happy to answer your question.
Thank you very much, Asami. Fantastic lecture. I have to confess that I'm very pleased to see all these results. Actually, you have a very rational way of approaching very complex congenital heart malformation. I guess that in your institution, you try to standardize the quality of care for these very complex congenital anomalies in order to try to predict and maybe give a more reproducible treatment for all these patients, even though we know that physiology sometimes are quite different from each other, and sometimes even a predictable operation can lead to a different result. However, in the way of producing better result, I think is a fantastic approach. So I will start with a question from the audience. Actually, we have a question from Rob Johnson, Alder Hay, who did a kind of big question. So the first question said, was there a mistake on the uni by decision algorithms slide? Both hybrid and by pathway have flows less than 2.
So can you repeat the question?
Yeah. he said, was there a mistake on the uni by decision algorithm slide, maybe referring to the borderline ventricle, because he said that both hybrid and bi pathways were flows less than 2.
Yeah, so so far this algorithm actually works in vast majority of patients. The patient who failed, I think we have 1 or 2 patients who failed. So those are the patients who had a critical aortic stenosis with combination of small left side. I think those subgroups are quite different from the patient who have just a small left ventricle with normal myocardium. So I haven't showed this slide, but before the hybrid era, so SICCH was quite aggressive doing primary biventricular repair for the small left ventricle. And so Dr. Van Nasser published a series, and their smallest LV volume is something like 17 or 18 index. And then they all survived. But obviously, in the current era, we're not gonna try to do a primary biventricular repair for the index volume of 18. We always try to buy time by doing the hybrid. So to answer the questions, all the patients who have just small left ventricle and no major aortic valvular stenosis, and then have a hybrid, and then have a biventricular repair, they all survive. And then we're quite happy with the decision-making process. The outlier is the patient who have an aortic valvular stenosis and small left ventricle. So those are the ones that much higher risk and then bit harder to predict what's going to happen. So I think the second or third example I just showed you, that the ventricle stay hypertrophied, it didn't grow, and then we end up having the normal. So that's the subgroup that we are worried about, and we'll be careful about.
Okay. So we have a comment from Attilio Lotto that congratulates for this great talk. Again, another question from Dr. Alderhay. He said, how do you measure intraoperative pulmonary pressure without coming off bypass? Or is it measured on bypass?
That's right. So this intraoperative pulmonary blood flow study is my favorite topic. I can give you another 1 hour lecture, but in essence, so when you completely unifocalize all markers and then reconstruct the central pulmonary artery, we place a additional arterial cannula to the reconstructed pulmonary artery. So that's usually the exact same size of your aortic cannula. Then you go ahead and give a cardiopedia, arrest the heart. So most of the unifocalization we do with on bypass, on beating. But once we are ready to do the flow study, we arrest the heart and then decompress the heart. And then we ventilate normally on the bypass with arrested the heart, because we want to mimic the normal kind of lung physiology. The one very important step is to place 1 or 2 suckers into the left atrium to make sure left atrial pressure is close to 0, because that will artificially increase the pulmonary artery pressure. So in that setting, so you arrested the heart, left atrium completely decompressed, and then you're ventilating the lungs. So in this, so in that moment, you infuse the total cardiac output into the additional cannula that you placed in the reconstructed PA. So obviously you need a lot of extra volume because you're running the pump as well as putting the flow into the pulmonary artery, and then we stick the needle next to the cardia, and then that's how we measure the mean PA pressure. We usually repeat at least 2 or 3 times, make sure that number is accurate. And then if left atrium is kind of overflowing, you really have to repeat the pressure until you got good setting pressure.
Okay, great.
Hopefully that makes sense.
No, it was completely happy with your answer.
Okay.
Again, another question still from Other Hay. Why do patients have a low SVC blood flow? That would imply some neurological problems since the flow is dominated by brain perfusion.
Yeah, so that's a great question. So we probably need, the much higher number of the patient to answer that question. But when we did it, so we have 2 studies in the last 10 years talking about this SVC blood flow and then BCPS outcome. The first study is some of the patients who have very low SVC flow. Couple of patients have brain abnormalities, and then another couple of patients have internal jugular vein occlusion or stenosis. So obviously, SVC flow is determined by your cerebral blood flow and or health of the upper vein. So yes, if you have a brain abnormalities and then diminished brain perfusion, and then SVC flow might be diminished. What we don't know is that, obviously, if you have, let's say, low cardiac output with a ventricular dysfunction, that might also gives you lower SVC flow. So we actually don't know the full kind of, we actually don't fully understand why some patients have a low SVC flow. What we know is that it does affect your post-BCPS physiology in terms of arterial saturation, and then the lower SVC flow patient have a higher rate of BCPS takedown.
Okay, great. So I see Alvise now is finishing the OR. Maybe Alvise want to make some comments and say hi to Azami.
Hi, Azami.
Sorry. How are
you? Yeah, there have been a lot of technical questions, and they were all great. I have one question for you because we have many residents here and fellows connected. And one thing that really impressed me when I was in Toronto with you is that you developed a lot of expertise in this all pathophysiological data. One suggestion from you for our residents or our European residents and fellows in terms of developing this knowledge, like something that you would suggest to the young guys.
Yeah, that's a great question and suggestions. I think what we really value is the I guess this all coming from the clinical practice, right? So we really have to value each patient, particularly the one that's challenging, and we frequently review data quite in depth, going through the echo, CT, CAS, MRI, and kind of have a in-depth discussion why this patient, behaving, such ways, and that'll be your kind of a personal, we call it the institutional memory, which you can develop as an individual, and then also you can develop as a team. For example, I usually write it down really impressive or challenging cases. And then when we have a similar case, we try to bring up those patients and compare. So those, and then when you have several cases like this, you can summarize, publish. But I think all the great research questions come from the daily practice, dealing with the challenging cases. So my biggest suggestion to the young surgeons and trainees is really pay attention to good case. Good case is usually a challenging case, and put it in your memory box so that you accumulate those great institutional memory.
Great. So I think we're running a little bit out of time. So Osami, thanks so much for sharing with us this tremendous knowledge for your great institution. It has been a privilege to have you with us in this international lecture series, and I hope that you can follow us during the next few months with other lectures and also with our journal clubs for our residents. So thanks so much for all the audience. Please, I sent you a link to for the website of the World Summit for Pediatric and Congenital Surgery, which is going to be in June in Bologna. Hope all of you can join us. Please check the site and check details for this meeting. So thanks so much again, Osami. Thanks so much to the audience. I will see you next time with the Journal Club for Residents, and hope you have a good day. Bye to everybody.
Yes, thank you.
Bye, Osami.
Thanks. Bye-bye.